Good morning and welcome to Empowering Older Adults, Strengthening Independent Living with Resources and Support. This program and training is supported by a grant from MetaFund. A bit of housekeeping. Today's program is being recorded. For audio and video, all participants are muted and without video to minimize distraction. To submit a question or comment, select the chat button at the bottom of your screen and send a message to Q&A. Questions will be forwarded to the host and answered time permitting. For closed captions, select the live transcript button at the bottom of your screen and click Enable Live Transcription. Well, and it is my pleasure to hand the floor over to the Executive Director of the San Francisco Interfaith Council, Michael Pappas. Michael, the floor is yours.
Trey, thanks very much. Good morning. I'm Michael Pappas, and on behalf of the San Francisco Interfaith Council and our collaborating partners, I want to welcome you to this fourth in a series of 6 online training sessions entitled Empowering Older Adults. Communities of faith are hubs where older adults feel safe, valued, and may escape social isolation. Faith and lay leaders entrusted with their spiritual care are more often than not first responders in instances when the well-being of older adults is at risk. To better equip faith-affiliated caregivers with the necessary insights, skills, and resources to minister to this vulnerable sector, the San Francisco Interfaith Council, in collaboration with the San Francisco Department of Disability and Aging Services and the Institute on Aging, supported by a grant from the MetaFund, offers this 6-week online training series entitled Empowering Older Adults. This week's training session, entitled Loneliness and Isolation, will be led by Dr. Carla Perissinotto, professor in the Division of Geriatrics of the Department of Medicine at UCSF Medical Center. The twofold focus of this presentation will be, first, to understand why loneliness and isolation should be viewed as a public health issue and something not to be ignored. And second, to identify tools and frameworks to begin to address loneliness and isolation in order to promote social connection. Dr. Perissinotto, we are so pleased to have you with us. Your impressive resume appeared in the program announcement. So as to maximize time for your presentation, I'm going to hand the floor over to you now.
Thank you so much, and it's wonderful to be here. I am going to pull up my slides, and I will say that I think we have the right ones up, is that I try to consolidate everything I've learned over the last several decades on loneliness and isolation into a brief talk for us, but this is so near and dear to my heart. So thank you so much for having me. I think you went through our objectives, but again, just to put us all on the same page, we're really going to be focusing on what do we mean by loneliness and isolation. We'll talk about what is the evidence showing that these affect our health. And then again, we'll end with talking about frameworks and solutions to addressing this. So it may not be any surprise to many of you that there has been so much media attention to loneliness and isolation, asking if this is an epidemic. And certainly these discussions were heightened even more so during the pandemic. And I want to start by also saying that just last month, Surgeon General Vivek Murthy actually sent out an advisory and a whole report calling us all to action and saying, we do indeed have an epidemic of loneliness and isolation in our country. And there's dramatic effects this can have on all of us. And so it is incumbent on all of us, regardless of our discipline, regardless of our faith background, that we actually address this issue directly. So I want to start with a little question from all of you. So I realized that I'm a loneliness and isolation researcher, yet you start reading and paying attention, and there's discussions of loneliness everywhere we look. And in a book that I bought my daughter, on one of the first pages when it's asking about different feelings, the book asks, how are you feeling, little fish? And the fish actually says, I feel lonely. So what does that actually mean? So in medicine, and I'm a physician by training and an anthropologist and a public health advocate, there's increasing talk about social determinants of health. Now, social determinants of health are all the factors that affect people's health, and loneliness and isolation or social connection are really part of the social determinants of health. What we've realized, and actually we've known this for a long time, but we often unfortunately ignore the things that are obvious, is that when you look at a whole person and the things that impact their health, we spend so much money in this country on health care. The healthcare only accounts for about 20% of someone's overall health. And so you think about the physical environment, health behaviors, socioeconomic factors, and loneliness and isolation. This is actually what's affecting all of our well-being. Yet the public health dollars and the attention in our medical framework that we have are not focused on the right things, frankly. And that's likely why we trail behind so many countries in terms of healthcare outcomes. So how do we actually define loneliness? So loneliness is subjective. It is a subjective feeling of being alone. Another way to think about it is that the distress that you may feel between the relationships that you have and those that you wish you have. So someone may be lonely because they've lost a spouse and they long for that relationship. In contrast, social isolation is more about the quantifiable number of relationships. It doesn't really talk about the quality of relationships. It's really more of a numbers focused thing. When you compare the two, so loneliness is subjective, isolation is more objective. Loneliness really talks more about the quality of relationships, isolation about the quantity. Loneliness inherently is unpleasant, but social isolation may not be unpleasant. For example, some may choose solitude to be alone, and that may be okay. So it's all about control and choice. When you look at the intersection of both of these, if you combine them, we really think about this on a spectrum of social disconnection. The R coefficient in the middle is really about how related these terms are, and they're actually not that related. The reason why I'm highlighting this is that we use these terms interchangeably, but whether someone is lonely or isolated or both may ultimately impact what we as faith leaders, as community members do to try to address this and try to help someone or help ourselves who may be experiencing any one of these things. So that's a little bit of background, and I'm going to frame this in the context of 3 stories. So as I mentioned, I'm a geriatrician and palliative medicine physician by training. I've spent the entirety of my career working in home-based settings, so seeing older adults who have difficulty leaving the home. And most recently, I've been working with M.H.S. Hospice as a hospice physician where I see people with serious illness at the end of life. So this is the context in which I'm talking to you. So I'm going to start with John, who's 82. He became stuck at home after COVID, or during COVID rather. In December in 2020, he had COVID, he fell, and in those early months, I think our public health community didn't quite understand that some older adults presenting symptoms for COVID were falls, weakness, cognitive impairment. So many people were not getting diagnosed accurately. He unfortunately has stairs getting into the home. He lives in an ethnically marginalized and unsafe neighborhood here in San Francisco. He has family nearby. When I ask him, he actually says his family lives down in the garage, but he has very little contact with them and actually did not want me to talk to them. He's been dismissed from many healthcare practices for inappropriate behavior, which I didn't find out until after I admitted him into my practice, and I soon understood what that meant. He interestingly described himself to me as socially isolated. Other things about him, which I think were relevant during the pandemic, he has a landline, he has a very basic cell phone, but that was it, which made also contact with the healthcare system difficult during the pandemic. When I asked him about additional technology, he said, don't even bother, I have zero interest. The second case is of Mel, who's 94 and he's dying of cancer. He's Jewish, he's a European refugee. He lives in an assisted living that caters to people of a different heritage than his. He identifies as atheist, and some also describe him as a Holocaust survivor. He doesn't participate in many activities, but he loves religious conversation. He's hearing impaired, English is his second language, and he, when I met him, requests aid in dying. And the third case is Jana, who's 2.5 years old and was born during the pandemic. She was born in July of 2020. She had limited social contact initially when she was born. She did try to meet family and friends to prioritize socialization. She's being raised in a bilingual and multicultural family. She has daycare 3 times a week, and she's also in an intergenerational home with a nanny twice a week. And she recently visited family and friends in Italy. So as I reframe those cases, the question is from a healthcare perspective, how do we think about addressing loneliness and isolation in a healthcare setting? My colleague Julianne Holt-Lundstedt and I published a paper just this January in the New England Journal about the fact that it's not that hard to actually begin to address this. It doesn't mean that we have solutions right away, but one of the first things we need to do is educate. We then need to assess our patients about whether they're lonely or isolated, and we need to respond. And we'll talk a little bit in detail what that means. In the same framework is no different than what you may be able to do as religious leaders and community members to address this. So when we start with educate and estimating health risks, so I love this slide from the World Health Organization, who's had a whole campaign about combating or addressing ageism. And what we'll talk about today is primarily about behaviors in social facilities. But as you see from their slide, what influences health in older age is a combination of all these factors, again, where it's not just disease and it's not just genetics and age-related changes, but there's a ton of things in our intrinsic and our external environment that ultimately affect our health. So if we think about my first patient, John, who is homebound since COVID, how would you think about his health risks? And if you're seeing him in your religious community, are you worried about him? And I'll tell you that traditionally in our healthcare medical record systems, what would be written in his record is that he has COVID-19, he has arthritis, he has constipation. Maybe someone would write that he has falls, but often that's not even included as a risk for his health. And what I would argue is that things that are missing from his health record and looking completely at John is the fact that he describes himself as socially isolated. I don't know if he's lonely at this point, but I wonder. He has mobility issues. Tech access ends up being something that is affecting his health because he cannot connect to the health community during the pandemic. And then he has this issue of inappropriate behavior that makes it difficult also to access healthcare systems and may ultimately impact his health. When I think about Mel, who's at the end of his life, the thing that we might see for him is that he has cancer, he has limited mobility. Many of my patients who have hearing impairment don't have that documented anywhere in the medical record, and people miss the fact that this impacts people's way of interacting. And what's not written in his record is the fact that he may be socially isolated, he may be lonely. There's nothing written about his living situation, and there's no information about the fact that he has a history of trauma, that he's a refugee, and that he's a survivor. And in the third case with Gianna, our under 3-year-old, we think about what are the risks that she has as she's starting her life. Well, unfortunately, there's this term pandemic baby. We know that early on she had limited exposure to infectious diseases, and how does that affect her over the lifespan? She's a second-generation American. Is this a risk or is this protective? She's Latina. She lives in a technically unsafe neighborhood. And then the other question on the other side of things, are there any protective factors that we can start thinking about at her young age? Is being in an intergenerational home protective? Is being second-generation American and that cultural heritage protective? And is prioritizing socialization from a young age protective? So let's talk a little bit more about these health effects. So the rates that we see on loneliness and isolation vary depending on what study you look at. Anywhere from 1/4 to half of all adults report some degree of social isolation. Prevalence is about 35% in those over 45. And actually, some of the more recent estimates suggest that loneliness is prevalent and is as much as 50% of older adults or adults in general. The research that I did in 2012 estimated 43% of people over the age of 60 reported some degree of loneliness. And then in the United Kingdom, there's a smaller percentage, which echoes our rates here, that show that there's a smaller percentage, around 10%, who feel chronically and always lonely. During the pandemic, what we saw is that there were a lot of negative emotions associated with this. Feelings of loneliness, feelings of isolation, although interestingly, frustration and stress were more common reports. So what predicts loneliness and isolation? So losses, something I think that you as faith leaders may see a lot and may guide your community members through. The death of spouses and partners, the death of other relatives and friends. We saw this a lot during the pandemic. Change in living arrangements, whether someone moves to a new community, has a loss of independence and needs to move to an assisted living, institutionalization, changes in physical health, including mobility, and certainly sensory changes like hearing and vision can impact our ability to connect with others. And then we have COVID on top of this, which affected so many people in so many ways, because maybe we were bordering on being isolated, but we were able to go out and suddenly we were all in lockdown. A key point that's also separate from what happened during the pandemic is that even before the pandemic, our trends in social connection were changing drastically. We saw on this fabulous graph that is published in the Surgeon General's report, the hours of social isolation increased monthly. Our hours of household engagement went down, companionship went down, social engagement with others have gone down. Non-household family social engagement went down by 7 hours per month, and social engagement with friends went down 20 hours per month. This is in graph form, but I can tell you directly, I see this in my own life. My husband and I are social people. We try to invite people all the time. We don't get reciprocated. We wonder what that's about, but we see that the invitation to dinner parties, to hang out, to have lunch is just not as common as it once was. This is also highlighted in one of Robert Putnam's famous books, Bowling Alone, is really talking about how our society has changed. A quote from one of my favorite poets, Rupi Kaur, she says, "The irony of loneliness is we all feel it at the same time together." There's so much to talk about isolation during COVID, and thanks to the Meta Fund, who also is funding this, they helped fund some of our research here in the Bay Area during the pandemic. And we found that our older adults were greatly affected by the pandemic, but in different ways. And I'm going to, unfortunately, not spend too much time on this, but maybe there'll be questions at the end. But needless to say, there were drastic effects on all of us. And I think we do not completely understand the effects of the pandemic. And I suspect that there were many lives lost solely because of the isolation and loneliness that ensued. And we're not capturing that in meaningful ways. How does this happen? Ultimately, we think that chronic loneliness really results in this emotional distress, as we started earlier, this discrepancy between the relationships we want, those that we wish we had, and we have a stress response. That stress response leads to inflammation, and that response also leads to what health behaviors we participate in and how we receive medical care. But if we think about inflammation and stress and its impact on all our organ systems, then it makes physiological sense why loneliness and why isolation can actually affect our health in different ways. The paper that started this on my research trajectory was published in 2012. It was a seminal paper at that time because very little, if anything, was written in the medical literature about the effect of loneliness and health. I started this work as a medical resident because I saw in my own patients that there were probably things that were happening in their lives that we weren't asking about as physicians or healthcare providers. We surveyed people over 1,600 people from a national study. And I was interested in if people were lonely, had worse outcomes in terms of death and declining function. Why did I pick function? I noticed in my own practice is that for older adults, what they're most worried about is maintaining independence and maintaining their cognition. And this is what I focused on. And what we found from this study back in 2012 is that loneliness was an independent predictor of functional decline and an independent predictor of death. An independent predictor means that when you remove people's other health risks, the traditional things we think about, high blood pressure, smoking, education level, you take all that away and loneliness by itself predicted worse health outcomes. And this was really just the start of my research career and why I concluded that we still have so much to learn, and we still do. Since then, there's been numerous studies looking at different organ systems and how both loneliness and isolation affect our health. In 2013, and then replicated again in 2020, we found that people had higher mortality, overall mortality, if they were both socially isolated and lonely. And again, worse health outcomes from both loneliness and isolation in 2020. I wanted to include this study that was just published in 2021, looking at results from people admitted to an intensive care unit. The reason I highlighted this is because we saw so many people during COVID be placed in the intensive care unit because of severe COVID. Well, what's interesting is even looking at people with critical illness, is that the people that did worse in terms of mortality and disability were those that had more social isolation. So again, there's something very clear going on here in terms of the effect on our health. When we look at serious illness in the population that I often deal with in hospice, we know that nearly 4 in 5 older adults are lonely, and social isolation doubles in the last 6 months of life, which is why your roles as faith leaders in working with people with serious illness and at the end of life is so important to help address some of this distress that could be happening as people near the end of life. As a geriatrician, much of what people come to talk to me about is their annoyance with taking so many medications. Well, in this fabulous study by my colleague Ashwin Kotwal here from UCSF, he showed that lonely older adults experience higher rates of pain, anxiety, depression, and insomnia. What does that lead to? This graph on the right shows that people with the highest rates of loneliness had much higher rates of polypharmacy, which means multiple medications, which has its own risks on our health. How does this all work? I talked a little bit about the inflammatory effect, but there's also, with social isolation, the fact that people aren't experiencing the benefits, the protective factors of socializing, and the lack of sources of support in terms of financial, medical, caregiver ultimately can impact how we receive and respond to medical care. My colleague Julianne Holt-Lundstadt wrote this seminal piece back in 2020 that demonstrated that the lack of social connection is as bad as your health of smoking 15 cigarettes a day, which means that this is not insignificant. And we need to think about that there's been so much focus from a public health perspective on smoking, obesity, and very little has been placed on loneliness and isolation and our need for human connection. In summary, summarizing, thousands of journal articles, I'm very confident in saying that loneliness and isolation in different degrees affect all of our organ systems, but important to all of us as we get older, our cardiovascular health, diabetes, our sleep and depression, you're more at risk for frailty, cognitive impairment. It leads to higher healthcare costs and increased mortality. So what does it mean to be older, and how do we think about us as we get older and our social connection? I have these numbers wrong, but if we start with the first patient, actually, number 2 here is actually number 1, which is John, who is starting to decline because he had a fall and now he's isolated. And the question is, can we change this trajectory of his illness so that he stays at full performance for a longer period? Number 3 is actually Mel, our gentleman dying of cancer. Now, unfortunately, he's already down here in the area of disability and nearing the end of life. But I wonder, can we make a difference in his quality of life by really focusing on the triggers for his isolation and loneliness and how to help him connect? And at the top here, number 4 is Gianna, who's just starting her life and at full performance. And what can we do early on to have her be protected so that she has a fuller life and full performance without going down into disability and frailty at a younger age? So how do we translate this into practice? So in addition to the Surgeon General's report that just came out, in 2020, on the eve of the pandemic in February, the National Academy of Sciences, Medicine, and Engineering published a report titled Social Isolation and Loneliness in Older Adults, Opportunities for the Healthcare System. I had the privilege of being one of the committee members for this report. And it was fascinating because we came out this report thinking, oh my goodness, now there's the pandemic, there's this new virus and it's going to overshadow this report. Well, it turned out that this report came out just in time because it highlighted the importance of social connection. What the report concluded is that we needed to develop a more robust evidence base, but an evidence base not on the science behind the health effects of loneliness and isolation, but rather what do we do about it now? They also suggested translating the evidence into healthcare practices, which means what can I do as a physician to address this from a medical and healthcare perspective? We need to improve awareness, which is why I'm so thrilled that you invited me to give this talk, including strengthening education and training. So this means that you all then have to do this all in your own communities. And then how do we improve ties between our healthcare systems and our community-based networks and partners that are doing amazing work meeting the needs of older adults? So this includes an assessment. So a couple of years ago, I gave a talk at a community of older adults. And when I asked people if they'd ever discussed feeling lonely or isolated with their provider, the response was that over 50% had never discussed with their healthcare provider and over 50% had never been asked. And this has been replicated in other studies. This was just my informal study in that community. But in truth, it's actually very easy to ask about this. So there's actually a great validated questionnaire called the UCLA Loneliness Scale. It asks people 3 questions. Do you feel left out? Do you feel isolated, or do you lack companionship? The more often someone feels these, the higher and the worse the loneliness. And the goal often is to think about, can we move people from feeling lonely all the time to feeling it less often or not at all? So how do we translate this into practice, and how do we respond? So there's been a lot of talk about something called social prescribing, which is this idea, as I mentioned early on, that the majority, 80% of our healthcare, or our health rather, is really about the non-medical things happening in our life, or the non-traditional medical things happening in our life. So what that means is that when I think about loneliness and isolation, I have to think about what are the drivers, what are the causes of what's going on. So I'll start with indirect interventions, which means there are things such as hearing and vision and functional needs that affect someone's ability to connect. With my patient, John, his functional needs is that he can't get down his stairs. If I address that, he may be able to get out of his home. I have a woman that I've been caring for recently who's very hearing impaired. And the day I gave her a sound amplifying device because she couldn't afford hearing aids, her life changed because she was suddenly able to talk with her caregiver. But then there's the direct interventions that we'll talk a little bit more about, which are social support, enhancing interactions, addressing maladaptive cognition. And I bet many of you work with here in direct interventions and may not know that that's what you're doing. And then, of course, there's the downstream consequences, is thinking of people who are isolated and don't have a community. And how do we think about advanced care planning? And how do we address related symptoms like pain, depression, and trauma that could be affecting their health? So what I do in practice is that I do ask about connection, and I talk about other health risks, and I talk advanced care planning. But what I do is think about in my patients, who am I focused on? What are their specific risks? Am I focused on loneliness or isolation? Why does this need to be treated? How long do I need to deal with this? And who else can help me in this practice? How do we define social connection? Again, a wonderful slide from the Surgeon General's report, thinking about there are 3 vital components of social connection. There's the structure, which is really about the number and variety of relationships, similar to isolation. There's the function in terms of what needs do those relationships serve us. For example, is someone providing emotional support, mentorship, or support in a crisis? And then there's the quality of relationships. So going back to the little slide in the book that I showed earlier, and when the fish said, I feel lonely, and then you turn the page and the fish says, but then I remember I am loved. This is an example of social cognitive training, is work that I'm sure many of you do with your community members, is helping people sort through those feelings of despair and loneliness. Going back to the Surgeon General's report, there's many different ways we can address social connection at the individual level, at the relationship level, at the community level, and at the society level. The importance of this is that we all have a role. And if we target just one, we're missing other opportunities. So there's roles, in some of the work that I do on a national level is really thinking about society and the public policies that are shaping our communities. So what evidence do we have about programs that may exist and what's going on? So if we think about social access and social support and the functional qualities of social connection, there is actually great evidence, for example, for volunteering. There's great work by Linda Fried looking at experience core. What's important about volunteering is that the data really shows that there's minimum time commitments. Doesn't mean that volunteering once a year is not helpful, but there is evidence that the more frequently you do this and more consistently, there's better evidence for this being helpful. Certainly group activities, some great papers on choral singing, and church attendance and participation, or I would say religious attendance and participation. I think many of the studies, unfortunately, historically use the word church, but I think we can broaden this to say religious or spiritual participation. And then there's certainly data looking at intergenerational programs, creative arts, housing sharing, and others, but hoping that we develop more work in this area. And certainly our colleagues in Europe and in Japan are actually a little bit more advanced than we are. There's also this concept of, in addition to social support, is social skills. So this other little fish says, I feel lonely. And then this little girl says, sometimes I feel like holding hands with a friend, which means relearning how to do these things and how to reach out for help and support. Here in the Bay Area, my colleague Ashwin Kotwal and I published a paper with our partners at Curry Senior Center demonstrating that older adults that were high risk for isolation and living in the Tenderloin had great benefits when they were paired with a peer. Over a 1-year period, we saw reductions of loneliness, depression, anxiety, and decreased barriers to social isolation. One of the participants said, it's like having a friend. There's a lot of friends I don't really want to be friends with, but it's nice to have someone who you can talk to, who doesn't look down on you, who doesn't find fault in anything you say or do, and just looks at you as a person. So some of this is really not rocket science, but it's getting back to the roots of connecting one-on-one with others. What was great about this program is it was initially funded by the Mental Health Services Act, and what they wanted was to connect people with services and professionals. Now, what people wanted was just someone to hang with. And it turns out when you hang with someone that you get along with, hey, suddenly you have a friend to go with you to the doctor. Suddenly you're seeing improved health behaviors. And this was really exciting. And we just received a grant from the state of California and UCs to study this program for another year. So we're really excited about this. We also know that there's other amazing programs. The Institute on Aging, one of our partners during this talk, has the Friendship Line, being around more than 50 years, a line that has been specifically designed to address the needs of older and disabled adults. And separate from other lines in the country, it has both a crisis line component and a longitudinal companionship program, which is incredible. And there's also data behind these lines to show that they actually can be effective. The Friendship Line, what we know from the Friendship Line is that in our study and looking at it, we found that people appreciated using the line because of the supportive connection of having a listening ear. We also know from the staff perspective, they felt that there's a cohesive team and the support staff, or the staff, really support their emotional well-being altogether. The other parts that were unique to the line is the importance of empathy, of understanding loneliness, of managing difficult conversations, and building rapport. There are so many different programs, and I'm sure you all could add to this, but the reason for showing this is that some of the solutions are in our very own neighborhood that we don't use often enough. And some of the solutions are really about getting back to our roots, is remembering how to connect with one another. If we think about spirituality and loneliness, there's a huge role here in terms of the role of spirituality, in terms of having someone or something to reach out to when you feel that no one understands you. Interestingly, some of the data on spirituality and religious participation is somewhat mixed. The mixed part with religious communities depends on who you ask, and partly whether someone feels like they're a part of a community where they belong. So we know, for example, in some religious communities, if someone had a gender identity or gender preference that didn't align with their community, that could be a problem. And so, or if they're from an ethnic group that wasn't welcomed in their community, that can make someone feel more disconnected. So ultimately, it's about how do you form connections and do you feel welcomed and do people welcome you into the community? I can't not talk about technology since here we are on Zoom and everyone wants to know about this. And the answer, of course, from a research perspective is always going to be, well, it depends. And it depends on what literature you read. But what I'll tell you, and this is a fabulous paper that looks very complicated, but I wanted to show you the numbers, but I will walk you through it. This is by Louise Hockley, who's one of the premier researchers in loneliness in the country. And what she says is when you look at contact versus in-person versus phone versus messaging versus video, the summary is that in-person is always better. It's always better. And all our tech stuff doesn't replace it, okay? But what is important to say is that there are times where that additional way of connecting is incredibly valuable. So when my father died almost 5 years ago, we developed a group chat. And the group chat included our family in Italy, our family in Mexico, our family in South America, my sister in New York, and we all connect there. We can't meet in person all the time because we're across continents, but that way of connecting has been a huge source of support. And what has happened over the years is that that chat, even though there's sometimes group fighting, which happens on the chat, and people come in and out of the chat, it really has been a source of support through my father's death, my recent cousin's deaths, surgeries my mom has had, the birth of my daughter, so many different things that we can share collectively. But it won't replace the fact that in August, we're having an in-person reunion for my mother's 80th birthday and my 45th. So there is some role here again for in-person, but remembering it's how we use the technology. So what do we do when evidence is limited? As I mentioned from both the Surgeon General's report and the National Academy of Sciences report, we're just starting to build the evidence around social connections and how much do you need and what capacity and what are community-based partners doing? And we look at this, and I look at this as a physician and public health advocate as what do I do at the individual level and what do I do at the population level? But some core principles are individualizing. What may work for me to feel socially connected may be different than what works for Michael. It's also important to talk about it. I think the one positive thing from the pandemic, there are a few, is that there's been more openness to talk about isolation and loneliness because so many of us experience it and to some degree. And then the third part is to think creatively. We may not know the perfect answer, but if we think critically with someone about how to make them feel connected. The Surgeon General puts it very concretely in terms of 6 pillars. Strengthening social infrastructure in local communities. How is our built environment built for social connection? Are we continuing to build single room occupancies and tiny apartments where you can't live together with others? How do we enact pro-connection policies? How do we mobilize the healthcare system where I work to make sure that we're including this in our evaluation of people coming to see us for health reasons? How do we reform digital environments so that they're helpful and not harmful? The Surgeon General followed this report with a report looking at the use of social media in children and the effects on health. How do we continue to deepen our knowledge on this topic? And how do we build a culture of connection? The Foundation for Social Connection nationally continues to work on policy changes and working together with the Surgeon General's Office on the National Strategy. I will also say that the World Health Organization is taking this topic straight on, and you will start seeing emerging things from the World Health Organization coming in the fall. So how do we go back to our cases? So with John, our gentleman who became homebound during the pandemic, my question is, if we address the structural environment and systemic racism, is that the answer, given that he lives in a marginalized, ethnically marginalized neighborhood and he has stairs living into his house? The other question is his disruptive behavior, and does he need some assessment of what's going on there to really help him connect better with others? In the second case, Mel, who's 94, a Holocaust survivor and dying of cancer, does addressing his religious identity and historical trauma help him feel more connected and help with his deep feelings of loneliness, part of which may be existential? And then the third case, which if you haven't guessed, this is my daughter, who is now about to turn 3, is, can we change her life course? And what can I do as a parent to help protect her as she gets older? So in summary, I'm hoping that I helped us define loneliness and isolation. We talked about loneliness and isolation, how they're linked to serious illness. We talked a little bit of the COVID pandemic, but I'm a little bit COVID pandemic tired. So I didn't touch a ton on it. I hope I taught you about a general framework, how to think about loneliness and isolation in terms of assessing it and how to address it. We talked about a few examples of evidence-based solutions, and then we are connecting here with each other. So thank you so much, and I'll stop sharing and see if we have some questions.
Dr. Perissinotto, thank you. I mean, this has been needed, comprehensive, and I'm really impressed about your holistic approach to everything. I wanted to share with the attendees today because somebody asked, yes, we will be sending the slide deck out with the recording link and some helpful links today. And I would like to also encourage you and invite you, if you have questions at this time, to put them in the chat, and we will ask Dr. Perissinotto. I have a few questions and would like to start with the Surgeon General's report on social connection and the call to action. You spoke both as a physician, as a mom, and I know that when we were in the waiting room, I asked you, I was so bold to ask you about your own religious practice and experience in community. So I want to give you permission to bring that perspective in, because I think it will resonate with the folks on this line. In terms of the Surgeon General's report, what do you think are some of the key things, takeaways that you have that you would like to drill down on and share with the folks online here today?
Yeah, so thanks for the question. And I think, those of us that have been working in this space, directly through research, have known about the health effects for so long. And I think those of you that work in the communities and see this directly know this is a problem. But to have the Surgeon General, our highest figure that really dictates where public health policies go in this country, really say this is an epidemic and we cannot ignore this. This brings this to a level of like, we can't ignore this. And all of us, our healthcare systems cannot ignore this. What I love about the Surgeon General's report, and I'll tell you where there may be some gaps, is that he says it's not just about this program and that program as a solution, but really thinking about as a whole, how are we going to build and continue our society as we move forward? It's not just about having a peer support system. It's how do you and I connect, Michael? How do we ensure that we still have dinner parties? How do we ensure that when we're building public spaces and new public buildings, that we think about places for connections? And how do we normalize this to make sure that we aren't moving away from the purpose of connection? I think one area where I'm still concerned about is financing. And I think we have a ways to go in terms of how things get paid for. I think I can say some controversial, maybe not so controversial comments here in the Bay Area, but our fragmented healthcare system and our payment system for healthcare is really fraught with problems. And our insurance companies dictate the care that we get and what gets paid for. And we need to put increasing pressure on our insurance and our healthcare systems to say social connection matters and it's impacting our health. And there's some studies that say it costs excess of $6 billion a year on our healthcare. And so we need to put the money to go with what to support our social connection. So so I'm just glad it's a huge start, because we've been behind Europe, we've been behind Japan in terms of, the United Kingdom has had a minister of loneliness for several years to really dictate a national strategy. The United Kingdom has the benefit of having a single payer system, so they can actually pay for social prescriptions.
Thank you. We're starting to get some questions in, and I'm going to defer to the questions from the attendees before I ask my own. What connection, if any, is there between loneliness and isolation and introversion and extroversion?
There's actually not as much as you would think, interestingly. I think we have this assumption that because you're an introvert, that that, you're more likely to be isolated, but there's actually not a correlation with that correlating with feelings of loneliness. So, and interestingly, well, I think that's what the data shows. I think in reality, I have a couple that during the pandemic, one of the partners who is an introvert was like thrilled not to have to be with a lot of people. And my very extroverted friends was like dying that she couldn't go out. So, yeah.
From Allie, thank you so much, Doctor. I was a longtime friendship line volunteer and always wonder what may be more tools to get LEP speaking communities to speak about isolation and loneliness.
So great. So LEP, I presume you mean limited English proficiency. Is that, yeah. So I think part of what we have to do, and interestingly, one of the big data gaps that we do know from the National Academy of Sciences report is that we don't know as much about limited English proficiency communities or immigrant communities. So it's a big data gap in terms of what's needed. I think that I don't have the great answer, honestly. I even think about in my own hospice population with volunteers, we have a huge challenge getting a volunteer community for our limited English speaking or non-English speaking patients. And so I think in many ways it's returning to our community partners that serve specific ethnic or linguistic populations and bringing them to the table to engage in research and engage in this conversation.
And I think that that's where many communities of faith can really step up and be part of the solution, because it's in those contexts where faith communities are really ministering to those in most need. I want to talk about a snapshot in time, because I was very impressed about your assertion that pre-pandemic, because of technological changes, loneliness and isolation started. I mean, or was catalyzed. I remember when I was in seminary, sitting around a table, a professor referred to the Greek village, where there was barely electricity, but they had something that was most civilized called the town square.
Yep.
And in order to be civilized, you had to go into the town square. You had to connect. Pre-pandemic, let's talk about pre-pandemic in your experience and in your professional time with others. Let's take the pandemic off the table for a moment. I remember being on Union Street and hearing a retail salesperson who had worked in Union Square lament the fact that because you could buy things online, that the era of brick and mortar retail was over. To me, I'm wondering, you talked about the advent of technology and its impact on this issue. I was wondering if you could drill down and say, how did you deal with things prior to the pandemic when things were exacerbated?
Yeah, so I'm going to answer that in a couple of ways. And one, as I mentioned, my daughter got to travel to Italy in January to meet some of our extended family. And actually it was my mother, my husband, myself, and my daughter, and we saw my extended family. And when we got there, everyone was jet lagged. Everyone went to sleep. I decided to go out on the square. And to your point with the town square, I mean, it was beautiful. I was in northern Italy. It was winter. And it was in the time before dinner or right after dinner. I don't remember exactly, but everyone was out. Everyone was out walking. So they were doing some of the key things for longevity. They were eating well, you eat pretty well in Italy. They were socializing, they were connecting with others, and they were exercising by walking. I'm like, I don't see that here. And that gets to this part about the built environment. And you were talking directly with people. And I think, getting to the point about technology and pre-pandemic, I mean, there's of course there's a role for technology, and sometimes that's important, but we're putting convenience first before social connection. And my father died almost 5 years ago, and my parents live in Santa Barbara. And when my father died, and my sister and I were helping my mom navigate how to adjust this new life, what we thought would be a solution, which was, we'll just automate everything. You don't have to go to the store. We'll have groceries delivered. You don't have to go to the pharmacy. My mom was like, I don't want all of that. She said, I go to Whole Foods and the deli counter, remember your dad and how funny he was about the type of prosciutto he wanted. and when I go to CVS, I know the pharmacist and they talk to me and they remember your dad. And I can't, that is not replaced by an app. And, so I think that that's really important to remember that in-person connection. That being said, I was very grateful when my mom was sick a few months ago and I couldn't get to Santa Barbara in time, and I could order a medication very quickly to be delivered to her home. So there's, I don't want to be about everything being a naysayer, but I think we're very quick to come up with convenient solutions and not the one-on-one interaction.
Charles Holmes asked sort of a question that piggybacks on what you just said, because it's one thing to be in the same place with other people. It's another thing to be civil to other people. He says, do you think the encouragement of manners towards all, including those who can't do anything for us, would help?
Absolutely. I mean, I really think that we've just moved away from very basic skills, which again, I mean, when we think about this, it's social cognitive training, which is like just remembering how to connect with each other. And I don't think we do that. We're just very insular. So absolutely.
I find just being out in society and smiling at people almost invites a conversation. And
absolutely.
It's a great thing. It's a great thing.
So when I finished my training, I moved to a condo near AT&T. I think I don't know if it's still called AT&T Park, where the Giants play. And, you go in and up and out of the elevator and like, no one talks to you. Like everyone's just in their own little thing. Then I moved to the Bayview, which is where I live now. And people say hi to you on the street. And it was like, what? People say hi? Our neighbors came and said hello. And I thought, and the irony is that the Bayview in the city is considered, it's a dangerous and terrible neighborhood. Well, no, people are actually friendly. I mean, it's amazing. Anyway.
No, I was out last night, and as much as people are lamenting, parts of San Francisco that are in the news, they said the neighborhoods are vibrant. And I believe that, and I think we can make them more vibrant and better places. Wanted to revisit something that is of concern. And, I know that during the pandemic, the faith communities above all were very cautious because we did not want to be the source of a super spreader. Okay? And we didn't have the capacity to monitor social distancing and PPE and sanitation. And so we erred on the side of caution. And San Francisco in general did, almost, to a fault. That created conditioned behavior, and that really exacerbated the isolation. We began to work remotely. We worshiped remotely, online. I'm wondering if some of that might have led to unhealthy behaviors. And if you could talk to that for a moment.
I think it has. And unfortunately, I would, so this is a big topic, but let me just say this. What was really scary and overwhelming for all of us during the pandemic is that science was happening in real time. Okay. So we were seeing in real time all the decisions that we as scientists and physicians were making on the spot. And sometimes we make mistakes, but we saw it. Usually we have years and time to do this in the background where the public isn't seeing things happening in real time. What did that lead to? It led to extremes on both sides. It led to extremes where like masks don't do anything, I'm not wearing them, to like, I'm never going to go out with anyone. And both of those caused harms. And what I've seen a lot in the older adult community is that because we saw the pandemic disproportionately affect older adults, there's been a lot of focus on ethnic minority populations, but older adults are the ones, regardless of ethnicity, that are the highest risk. But it is the greatest discrimination that we continue to discriminate against older people and not realize that that is who we need to worry about. That being said, we have taken it to an extreme, and now we really need to come back. And yes, the pandemic has been affected, but our therapies that we have, our treatments, our understanding are so much better, that our risk of dying from COVID is so much less than what it used to be. And frankly, the longer term risk, and we don't have this data to show because no one's doing these studies, but I firmly believe that if we continue to isolate ourselves and continue these behaviors that we have from the pandemic, that is going to more negatively affect our health. I saw my own patients die from isolation directly because of being isolated, being cognitively less engaged, physically less engaged, and I saw people die because of delayed medical care. I continue to see people with advanced or stage of cancer because they couldn't get into the doctor, they wouldn't go. So that is a long answer to say that, yes, we need to really rethink about how to reconnect. I keep saying this, but undo some of those bad habits.
Thank you. I remember growing up, my grandmothers, God bless them, their companions were the TV. And today ours are our devices. In terms of breaking some of that, what recommendations do you have? It's an addictive behavior.
It is an addictive behavior, but I think it's like many things that require behavior change, but it's, I don't think that, let me just say this, that I don't think it's an easy answer, but it's going to require a conscious effort, much like it's a conscious effort to say, I'm not going to have that extra piece of chocolate. I'm going to park a little further so I walk. It's the same thing with social health. So I will tell you, even this week, I had a colleague in town. I was like, I don't really want to go meet with someone. I just want to go home. But honestly, because I study this, I'm like, no, I'm going to make this a priority. And inevitably, like, I have a good time. But I mean, it's a conscious decision I have to make, to say, I want to engage with others.
Thank you. I mean, I think in part you're giving permission to people to connect. And I have to tell you, during the pandemic, one of the comments and the observations I made is that one of the greatest things that we as communities of faith can do is help navigate people back to connectivity.
Yep.
We've had some great comments, and I will send them to you, the ones in the chat, but they weren't questions. But I'm going to give you an opportunity right now as we come to a close. This is going to be the last question, to make the big ask. You have partners in this community, faith leaders and lay leaders. What would be your big ask of our sector and its leadership to help you in your work?
Yeah, my big ask is to actually foster these conversations with your community, because I think that this is on people's minds. And so actually addressing it directly in your sermons or whatever way that you speak to your community, and creating open forums for people to talk about how they're feeling and to ask members directly what the solution should be. We are often too quick to say, this is what you need to do. But when we ask people, what do you need? That's often when we find the answers.
Thank you. That's
Sure.
the last word. I will tell you though, you've given me permission to invite guests to dinner. How's that?
There you go. Exactly.
I love
that
to
sounds
cook, and so that's what we're going to do.
Yeah.
Want to thank you, Dr. Perissinotto, for this enlightening, illuminating, informative, and helpful conversation. Again, this will be sent out to our 5,600 e-subscribers, and we encourage them to share it with their friends and constituencies. We also invite you to join us next Thursday at 8:30 a.m. for the 5th in our series of 6 trainings on empowering older adults that will focus on ageism and ableism. So thank you very much. And that concludes our program for today. God bless you and God keep you.